Well, welcome. Tonight we have an old friend on the show who is here to talk about different viral conditions and flus. And tonight we're going to talk about a new topic that is not about viruses.
Well, indirectly, perhaps. We're talking in general about antibiotics, what they're good for and what they're not good for, and how some infections are getting more and more resistant to antibiotics, and we'll talk about those as well.
So let's start with an introduction.
Okay. Michael Newstein. I've been at Milford Regional now for almost 20 years, 18 or 19 years. I'm an infectious disease physician. I see people who come to the hospital or who have other infections, and I enjoy my time there at the hospital. It's a good place.
And one major claim to fame, a brilliant daughter, a brilliant, beautiful daughter at Holy Cross who's about to graduate.
Absolutely. Yeah.
So now what is she going to do next year?
Well, she's going to California, where she'll be in City Year, which is an AmeriCorps teaching program.
Oh, how nice.
Like your daughter. She may be interested in education, so she'll get some practice doing that.
That'd be great.
Yeah.
So now, antibiotics. Mm-hmm. What are they good for? What aren't they good for?
Well, whenever I talk to medical students or residents about antibiotics, I like to sort of take a historical perspective, because antibiotics really revolutionized medicine and probably extended everybody's lifespan on average. It's part of why many of us live out of our childhood or don't die of things like pneumonia as much as we used to 100 years ago. Antibiotics were wonderful, and 50 years ago people thought that infectious diseases would go away because antibiotics were so good. You wouldn't need people like me, like infectious disease
Bugs
physicians.
wouldn't evolve.
Yeah, but it turned out differently. So antibiotics are really good. They for the right organisms, the right bacteria, antibiotics can wipe out the bacteria and cure your pneumonia or your skin infection or your urinary tract infection, for example.
So now we keep reading about how bacteria evolve. Mm-hmm. The gram-negative with their little arsenal of weapons to fight off antibiotics. How does an antibiotic actually work?
Well, that's interesting, because the first antibiotics, well, some of them anyway, the first one probably that everybody knows of is penicillin. And that was actually found it was by accident. Somebody was growing bacteria on a plate, this guy named Fleming, and some mold got on that bacterial plate, and they saw that the mold was killing the bacteria. And so, smart guy that he was, he isolated the protein, the substance from the yeast, the mold that was inhibiting the bacteria. That turned out to be penicillin. Antibiotics are substances that specifically interfere with bacteria and don't harm us, so they're good in that way.
So they're interfering with the bacterial reproductive cycle, basically.
Yep.
So they won't let them multiply.
Or they kill them. The bacteria are different. Bacterial cells are different from our cells, so we can kill bacteria and not harm our cells. And if it's the bacterial cell wall, which is very different from our cell membrane, or the proteins, or the DNA replication or RNA replication of bacteria is different. So that's
I guess people never understand. You've got a bacteria. Mm-hmm. Penicillin, when I think of something that attacks humans, heroin, right? A respiratory inhibitor.
Yep.
I take enough heroin, my body can't breathe. Mm-hmm. I stop breathing, I die.
Yep.
Pretty simple, I can understand that. If I can't exercise my lungs, I die. Mm-hmm. Bacteria don't have lungs. So how do we kill it?
Well, it's sort of what I was getting at, that, we're both living things, bacteria and us, but bacteria have different structures that we don't have. As I mentioned, the bacterial cell wall is different than anything that our cells have.
So am I piercing the cell wall and basically busting a bacterial cell open?
That's how penicillin works, yeah.
Now, I read about certain bacteria, I think it's the gram-negative, that have almost antibiotic pumps, that they develop ways of encapsulating, and we put it in, it pushes it out before it can kill it.
Yep.
What kind of things have bacteria developed to fight off antibiotics?
Well, if you're getting to like the microbiology of all this stuff, and before we were purifying antibiotics from mold, mold was out there and fighting with bacteria on a piece of rotten bread, for example. There's a war going on. And the mold would be secreting stuff to inhibit the competitors, the bacteria. So that's been going on for a long time, and bacteria, even before we started giving antibiotics, say, well, we'll make a protein that, for example, chews up penicillin, which is out there. And so...
So an enzyme to attack penicillin.
Yep.
So now, as we talk, my darling bride is allergic to penicillin. She found out once when she went to a Merck facility where they make penicillin. She did not know she was allergic, but got an interesting reaction by being in the facility. What makes people allergic to antibiotics?
Well, you can be allergic to anything, and there are a lot of ways to answer that question. I mean, part of it is, I wonder if your wife was allergic to the mold that produced the penicillin.
Oh, okay.
And that was a problem, and it's actually something that I deal with all the time, because presumably this was a few decades ago, right?
About 35 years, yes.
Yeah. So antibiotics back then may not have been as pure as they are now. So some of the allergies aren't to the actual drug, but to the drug, what produces the drug, which in the case of penicillin is mold. So that's part of it. But some people are truly allergic to antibiotics. And, any foreign substance you can get allergic to.
So now when I'm allergic to the mold, am I talking about like endotoxin? Am I talking about cell wall bits that were left in there?
Probably cell wall bits, yeah.
And then you start reading how over the decades, the pharmaceutical companies have developed new classes of antibiotics.
Yeah.
Why?
Well, it's a race. We talk in microbiology and infectious diseases, we talk about it's an arms race. So, for example, staph bacteria, which is a gram-positive bacteria, lives on our skin, occasionally causes skin infections. So we call them cellulitis or, boils, things like that. When penicillin was first discovered, it was great for that. It would take care of all skin infections. But about 10 years later, the staph bacteria started secreting this protein, this enzyme that chewed up penicillin. So they had to find other drugs. And thankfully, pharmaceutical companies, as much as people don't like them, and I don't like them sometimes because of the prices they charge, but if it wasn't for pharmaceutical companies designing these antibiotics, we wouldn't have life-saving or bacterial-killing drugs.
But now, it seems like the pace of antibiotic development has fallen off. And a lot of it's blamed on the fact that, when you think of penicillin or any of the cillins,
yeah,
everybody views them as dirt cheap, so there's not a lot of profit in them.
And also, people tend not to be on antibiotics all the time. Some people maybe, but most people aren't. So if you have a drug, a cholesterol-lowering drug, for example.
Oh yeah, you take it
people
every day.
Every day. Antibiotics hardly anybody takes them, and when they do take them, it's for a few days. So it's a niche drug. And that's a problem. I deal with pharmaceutical companies all the time. They come up with these fancy new drugs. Sometimes they're antibiotics. Sometimes they're very helpful. But they want to make money. They want you to use these drugs for everything. And our job is to say, well, there's some indications for these drugs. Yeah.
Now that's one of the biggest issues, though, is people using antibiotics for the wrong reasons.
Yep.
So bacterial infections,
Yeah.
those are appropriate.
Yeah.
Okay, I've got the flu. I've got some antibiotics in my drawer left over.
Yeah. So people sometimes will know when they have the flu, the body aches, the head aches, fever at 103, and chills, wrapped up in your bedspread. That's the flu. And often people will know it's a viral infection, or they have the cold. They have a cold, runny nose, and low-grade fevers. Those are most often viral infections. Even sinusitis is often a viral infection. Pharyngitis, sore throat, is usually a viral infection. All those things are usually viral infections. And viruses do not respond to what we call typical antibiotics. We usually don't have any drugs against viruses, with some exceptions. So antibiotics won't do anything for those infections.
But taking it, doesn't it have a negative effect? Couldn't you be strengthening bad bacteria?
Exactly. You could be encouraging the bad bacteria to come on board. One of the things I also always tell residents or medical students is, our body is full of bacteria, and most of them do good jobs in our stomach.
GI tract and
Yep. If it wasn't for the bacteria in your stomach, you couldn't digest a lot of food. There's bacteria coating our skin or mucosal surfaces that do a good job inhibiting infections. So that's probably the biggest problem with antibiotics. And they've studied that. They know how to look at those trillions of bacteria in your gut and say, the antibiotics just totally rip up that ecosystem that you have in your stomach.
Now, that's always a question. Okay, so I have a bacterial infection. Unless, again, my medical training is limited, to being kind. Unless I'm on an IV, you're kind of nuking me, I'm going to take a pill. How does that work in my stomach at pH 3.3, and then in my GI tract? I thought antibiotics were like non-denominational murderers. Any bacteria around, it's going to attack. My GI tract needs my bacteria.
Yeah.
I like my bacteria.
Yeah. So that's what happens. You take antibiotics, you'll kill off a lot of the bacteria in your gut, and oftentimes you get diarrhea. And there's certain types of diarrhea. All antibiotics can give you a little bit of diarrhea, but we're scared in the hospital, particularly of infections that can cause diarrhea. And some of them, this one called C. diff or C. difficile, is unfortunately pretty common in a lot of healthcare facilities. And that attacks your body after the good bacteria are wiped out. This bad bacteria gets in there.
It's like you've wiped out the neighborhood and somebody's moving in, not necessarily the families you want.
The analogy I use is, if you have a nice lawn that's well protected and tightly packed with grass, the dandelions won't come up too much. But if you start playing football on it, or have your dog dig holes in it, you'll get a lot of weeds growing in there.
But now, realistically, when we think of even a septic system in our house, we have little packets of good bacteria that we can flush down the toilet to kind of enhance the good bacteria. If I have an infection and you give me a lot of antibiotics, you've wiped out all my bacteria. How do I get the good stuff in there and tell the bad characters not to go?
Yeah, Well, there's no perfect way, but we're learning more about it, and some of it you can get from the names. There are things called antibiotics, which are these substances that kill bacteria. And now people are talking about probiotics, and what probiotics are either bacteria or in some cases yeast that you can take by pill, or even things like yogurt. Yogurt is probably a very good formulation of these probiotic organisms that can go into your gut and sort of help protect your gut and build up your good bio-defense system there.
I just have this issue with yogurt mentally, that here's a seething cauldron, a microbiome of who knows what flora, hopefully it's controlled, but
Yeah.
and then I'm putting it inside of me.
Well, most bacteria are harmless, and some bacteria are beneficial. Some bacteria are harmful. So all people get hung up on bacteria. Oh, I have these things on my skin or in my stomach, but they're good for you often.
But Michael, they say bacteria, I think of E. coli. I think of the bar nut study. When I read that said, somebody went around these major cities and tested the bar nuts, and 80% were contaminated with E. coli. So when you say bacteria, I'm thinking, okay, somebody didn't wash their hands after they performed a biological activity, and they contaminated these bar nuts, and now I'm no.
Well, it's the same stuff even that's in literally mother's milk. Mother's milk has lactobacilli, populates the baby's gut. So think of it as mother's milk.
That would be better to paint the picture. Now, the old days, when I was growing up, and it was 10 days, 14 days, it seemed like, kind of like aspirin. You're an old man, you're over 50, take 81 mgs a day. It's the only drug I know prescribed per human, not by kilogram. But it seemed like antibiotics were prescribed that way, right? 10 days, 14.
Yeah, and I know some infectious disease physicians who say that that's really not, there wasn't much science on those initial recommendations. If humans were born with 4 fingers on their hands, people would say take 8 days. But we have 5, so we say take 10 days. It was arbitrary. So those initial recommendations came out there because they said, well, antibiotics are safe, which they're probably not that. They're relatively safe. They're safer than a lot of other drugs. They say, why not? Just treat for a long time. You'll get rid of the infection. No harm, no foul. But there are some problems with taking antibiotics for a long time, or certainly taking them when you don't need them.
Well, we've talked about one, that you're wiping out the beneficial bacteria that we want.
And that's probably the biggest one, honestly. We're learning more and more, as you described, how important that microbiome is for health. And, this is an expanding science, and I only know this peripherally. But that bacteria in the gut does a lot of almost magical things. One is to fight infections. But people think even things like obesity, some bacteria help you not put on weight. Some bacteria may even regulate your mood and anxiety levels. There's a lot of stuff going on with that. So it's an integral part of your healthy body to have these nice friends in our intestines, and we don't want to mess them up.
I mean, it sounds terrible, but the technical term of diarrhea is yucky. I mean, nobody's pleasantly experiencing. But there are real serious physiological effects if I am not properly digesting my food, right?
One of them is malnutrition, because some vitamins need the bacteria even to be absorbed, vitamin K in particular. If you can't absorb vitamin K or make vitamin K, your blood won't clot properly.
So realistically, we need to find the right optimum treatment. Another thing is sometimes people say, okay, I've been taking my antibiotic treatment for 3 days. I feel great. I can stop.
Mm-hmm. Yeah, you don't want to do that, because although doctors have changed their recommendations, and you don't hear too many people on antibiotics for 2 weeks or for routine pneumonias, for example, anymore, more and more, I think, medicine and infectious disease is a science. We do experiments and we say, well, for most pneumonia, 7 days is good enough, and we know that 5 days may not be. So I think you can be pretty confident now that if a doctor prescribes something for a certain amount of time, they mean you to take it for that amount
For
of
that
time.
amount of time.
Yeah.
So, again, as I look at shortening, a lot of people who aren't exposed to the science don't understand that, I'm oversimplifying, but I have 100 bacteria. If in 3 days I've killed 80% of them, well, the 20% left are the strongest against.
Yeah.
And when they start multiplying, I'm going to have a much larger challenge, a much more difficult challenge to get rid of
Yeah.
all the children of the 20%.
Exactly. So probably the worst thing you can do, it's bad not to finish your course, but say you're taking an antibiotic that's 3 times a day. Most of them now are once a day, but in the old days, and there's still some that are once or twice or 3 times a day. If you take it or you miss days, then you're allowing that resistant subpopulation to outcompete the other bugs, and that's a sure
Just makes
way.
it worse and worse,
Yeah.
trying to get rid of that subpopulation.
So you certainly should take it as prescribed and for the length of time prescribed.
We know penicillin. In the old days, we heard Keflex, super antibiotic. What is the evolution that antibiotics have taken? Because we don't understand it as laymen.
Yeah, well, the first group, there were really 2 early antibiotics way back at the early part of the last century. One was penicillin and similar drugs, and the other were sulfa drugs. Sulfa drugs were out there, and those were made in a lab. They weren't derived from an organism. So those were the first 2 classes. And then earlier on in that golden age of antibiotic development, every few years you get a different class. So you have the drugs that are similar. There are a lot of drugs that are similar to penicillin. One of them are called cephalosporins. You mentioned Keflex, which is pretty common. And a lot of drugs are like that are sort of distant cousins to penicillin, that your wife probably could take. Generally, the cross-reaction.
She's fine with Keflex for,
Yeah.
And
that's one of the things we deal with all the time is people can get allergies and trying to pick out the safest drug for that. So cephalosporins, and then there are newer drugs that came out, maybe 20, 30 years ago, like we call them the quinolones, like Cipro and Levaquin. Those are very potent drugs, which are great for their particular uses, but they tend to have even more side effects.
But aren't I reading as a fluoroquinolone or that seems to be overprescribed and causing large amounts of side effects?
Oh yeah. Yeah, fluoroquinolones were, again, they're great drugs. They're very powerful. You take them by mouth, you can get a good level in your body, and they're really strong against things like gram-negatives, as you mentioned, E. coli. So, people love them for urinary tract infections because you take 1 or 2 doses and you're done.
Wham, it wiped out everything. But it feels like you're throwing a hand grenade into a schoolyard.
Exactly. So that in fact is one of the things that we focused and a lot of infectious disease physicians were focused on. And it's actually a federal mandate that all hospitals have to have something called the Antibiotic Stewardship Committee. And so that's another committee I'm involved with, another meeting. So we look at things and we say, well, the fluoroquinolones, those are great drugs for their purposes, but we have to make sure they're not used for simple things that you could use Keflex for.
I have a mouse. I'm throwing in a hand grenade.
Yeah.
Well, what happens if you miss?
Well, it is a hand grenade particularly, or a nuclear bomb for that matter, for your biome, for your friendly bacteria. You wipe it out, and those drugs really predispose you to things like C. difficile or more resistant organisms. Plus, they have other side effects that you rather not
And I
use.
mean, that to me, if I can live with penicillin, one, the cost.
Yeah.
And just, let's face it, today we have to deal with insurance agencies and what they pay.
Yeah.
But two, the risk. If I'm throwing in a nuke and something survives, what do I have to go back?
Exactly. And that's a big problem. I take care of a lot of people who have, chronic lung conditions, for example, where they're getting a lot of infections all the time. And you have to pick your battles, so to speak. You can't use antibiotics for everything. We save them for when we really need them. But we're all in the stewardship subject. One of the things that everybody wants to put out there for the public is, as we were getting to in the beginning, a lot of infections are viral infections. So what I hear, I don't take care of people in the office setting that much, but I hear from my friends who are internists or pediatricians or family practitioners. And so, the classic thing would be a young kid with, a sore throat. You can test to see if it's strep, but if it's not strep, it's probably a virus. So you don't need antibiotics for that. But a lot of people want antibiotics because they think they're the wonder drug that works wonders. But if it's a virus, it's not going to do anything, and it has some risks.
But what do you do then? I mean, is there an antiviral Keflex?
Viruses are a lot more, well, I don't want to say more complex, because some ways they're more simple than bacteria. They're smaller and have less
But their
genes.
elegance is their simplicity.
Yeah, but their simplicity makes it harder to kill them or stop them. So there are antiviral drugs. The flu, we're filming this in late February. The flu is really raging right now. Hospital's full. Ed Kelly likes that. So in the flu, we have a drug that's not great, but it does pretty well in mitigating some of the illness of the flu, called Tamiflu. So there are some drugs like that. If you have a cold sore, there's a good, or shingles or chickenpox, there are good drugs against those classes of viruses. But most other viruses we don't have drugs for. And if you have, quote unquote, the flu, it could be influenza, it probably is, but it could be rhinovirus or adenovirus. And we don't have any treatment for that.
I was going to say,
Yeah.
But I mean, realistically, you can take antibiotics till you're blue in the face, and the virus is going to sit there and say, really?
Yeah.
Michael, that's the best you got?
Yep. So you don't want to use them, and one of the battles that all us in the medical profession try to work on, and if you go into doctors' offices, you'll see signs saying, that you should see them, I think they are there, that bacteria really, antibiotics really only work for bacteria. Your sore throat, your cough, your sinusitis may all be viruses. And, that's what a doctor can help figure out. And the answer to going to a doctor's office isn't always antibiotics. It could be reassurance, or take some medication for your symptoms.
But it is safe to say, don't self-medicate.
Exactly.
The physician gave you X number of antibiotic pills.
Mm-hmm.
You should be done when the bottle is empty.
Yeah.
If you got half a dozen left over or a dozen left over, you could be doing yourself a lot more harm than good by taking them.
Exactly. And it's very difficult for me in that scenario where somebody is pretty sick and does develop a bad pneumonia, and if they've been taking, the Keflex that was left over, and messes things up because I don't know what's going on. Is the bacteria partially treated? Is it resistant bacteria? No, you shouldn't.
Well, I mean, the thing that I guess worries me the most is if a physician believed that my proper treatment requires 5 days, whether it's a pill a day to whatever the physician looks up, and I got 5 or 6 pills left, and I feel good, so I stop. One that scares me, that did I really fully treat the bacteria? But 2, what am I going to do with those 4 or 5 pills?
Yeah, you don't want them lying around because
next time I take them for a day and a half, I've wiped out the most susceptible bad bacteria, and I'm creating a really fertile area for the bad characters to flourish.
Exactly.
Now, I read the hospitals, Ed Kelly will hate me, are the scariest place to go because people have open tubes going into their arm. They're on IVs. It seems like certain bacteria really love the fact that you're opening up my veins to let them in. How much of a worry should that be?
It's a huge worry, and it's something I deal with every day. Hospitals are life-saving places, but you have these people there on all sorts of antibiotics. And once you go into a hospital and you put on these antibiotics, as you mentioned, their flora gets changed, and now they have resistant E. coli in their belly. They might have resistant staph on their skin. And there are different organisms in a hospital than they are here. And again, there's bacteria everywhere.
Right.
There's bacteria on that coffee cup.
Well, there's not a sterile, I mean,
Yeah.
when I built the plant to make API, active pharmaceutical ingredient, the
Yeah.
sterile rooms weren't really sterile, but we went through extraordinary measures, wiping down walls, ceilings, floors periodically, double gloves, the whole 9 yards, to be as clean as possible.
Yeah.
Still didn't mean it was sterile.
Yeah. So we do our best, and Milford Hospital, I think we've taken it to the next level. We actually have, they call them robots, but they're little machines that shoot UV light into patients' rooms after they've left. And that does a pretty good job of killing most of the bacteria, even the spores. We mentioned C. difficile. It actually can leave spores, which are really resistant.
So it can actually kill C. diff spores? Because, I remember when they talked about certain anthrax or whatever.
Also has spores. Yeah.
The spores were the killer.
Yeah.
Because unless you could get some kind of chlorinated compound on it, it was almost impossible once a building or something was contaminated.
Yep. And C. difficile is similar. It's also a spore former. So, yeah, but UV light does it, and chlorine. So we use a lot of bleach in the cleaning rooms. We use the UV lights. We have the alcohol dispensers outside of all patient rooms. And the alcohol does a good job, but it doesn't work on spores. And there's some viruses like norovirus, which also has been around a lot this winter, which causes diarrhea. Those certain organisms like norovirus are also resistant to alcohol. But alcohol is good.
I remember down in D.C. at one point, the big anthrax at the post office scare where they sealed the building and pumped in chlorine gas. Because that was the only, let's face it, why does C. diff make spores? Because they don't like Newsteins. People like you are not popular to C. diff spores, so they make the spore and it's really hard to kill it.
So what we're getting at is that hospitals, despite our best efforts, aren't totally safe. There's a risk to being at one. And we tell that to patients sometimes where they're like, "Oh, doc, can I stay one more day in the hospital?" And I say, "Well, if you need to, but there's a certain risk despite all we do of being in the hospital. So if you don't need to be in the hospital, you shouldn't be in one."
The good news is 99.9% of the patients come out of this okay. Bad news is you're the one
Yeah.
that breaks the curve.
Yeah.
So you take what you can, you go in, you nuke the room with UV, which is probably, bleach, chlorine is best, but I can't imagine you're going to spray chlorine all over a room and not have Ed Kelly really upset at how much equipment you've ruined.
Yep. And the other things that other hospitals are doing are vaporizing high potency hydrogen peroxide. That works as well, but that takes longer. It takes like 2 hours.
I was going to say, isn't it hours of exposure?
Yeah. So the UV light kills things in a couple of, like 5 or 10 minutes, basically.
That's got to be a pretty strong dose of UV light.
Yeah, I think it's UVB or A. I forget which UV light it is.
That's for the physics people.
Yeah, but it's potent.
So now, it seems like the pharmaceutical companies aren't investing in new, classes of antibiotics. Your sulfur drugs seem to be, okay, that's a new evolution. And when the bugs evolved, we had the next class. Now we hear about MRSA and other really bad actors. Those are the illegal immigrants of your world.
Well, MRSA's been around for a while. That's a staph bacteria that's very resistant.
Where does it come from?
Well, it's on our skin, what I tell everybody. A lot of us have MRSA on us now. And if it's sitting on top of your skin, it's not minding its own business, no problem. We probably all have had MRSA land on our skin and maybe visit us for a day or two and then move on. Some people, it sort of sets up shop and they're colonized with it. But then if you get a break in your skin,
Like an IV tube being put in?
Yep, an IV tube or even, just a little scrape, it can form an infection, yeah. So, and MRSA is resistant to Keflex, which is our big skin antibiotic drug.
What's Keflex on steroids? What do we have if Keflex doesn't?
Yeah, well, we have to go to different antibiotics, and it's funny, some of them are new antibiotics, but sometimes we reach back to the oldies but goodies, and we talked about Bactrim and sulfa drugs, which are somewhat risky. A lot of people are allergic to them. They have some side effects, but Bactrim has sort of come back in some ways. The sulfa drugs have come back because they're generally pretty effective against
Well, but
MRSA.
isn't it, again, to somebody naive, the bacteria have migrated to fight the new classes, and somehow they migrated in a way that maybe the old ones,
Yep,
now they're susceptible.
exactly right, yeah.
So maybe the old, cheap, reliable guys, I think I still took penicillin last year. Didn't seem like there was any need to,
Well,
go any stronger.
penicillin these days is not used for too many things because there's still a lot of resistance to it. But Bactrim, an old drug, yeah, we use it.
What are the kind of side effects? If I go, because obviously to a layman, doc, give me the tough stuff. I can take Keflex. But what are the side effects besides one wiping out my GI tract? And
Yeah, well, depends on the drug. As you mentioned, like your wife, anybody can get allergic to drugs and antibiotics, and certain antibiotics have have a higher incidence of allergy. Bactrim for one, certain of the penicillin classes are another. And some are sort of particular to the particular drug. We mentioned quinolones. They have a lot of side effects. They can make your skin very photosensitive, which is more of a nuisance, but you can get a bad sunburn. But it can affect your joints. It can affect your heart rhythm. That's a scary one. And a number of antibiotics can affect your heart rhythm, for example. So we have to be very careful about how we dose them.
Well, I mean, there's a lot of, that's why you go to med school forever. You know, you start thinking about, I mean, I had some dental work done, and I had no idea that the Novocaine had epi in it. Till we were talking, and he said there's a limit to how many carpules of Novocaine I can give you, because the epi can really do bad things to your heart if I give you too much.
Yeah, there are a lot of things like that. Some of the antibiotics have additives.
And you sit there and say, you know, another reason why do the treatment and don't self-medicate, or even worse, half-medicate yourself.
Exactly.
So where do you see people going? I mean, they go to a physician, determine if it's viral or not. If it's bacterial, they come up with a course of action. What is the treatment of last resort in your mind?
Well, you know, you mentioned the gram-negative infections. Those are actually, to me, scarier than things like MRSA, which are gram-positive.
Let me stop you for a second. Sociology major out there says, gram what?
Yeah, we've probably done gram stains in our day. It's just a very basic way of characterizing bacteria, which we put bacteria into two big families that infect humans. One are gram-negatives. As a broad generalization, those are the things that live in your gut and in your urinary system, cause urinary tract infections, occasionally infections in your abdomen. Gram-positive infections, gram-positives are things like staph and strep that tend to live on your skin.
So now when you look at UTIs, I mean, people don't think of urine as the most clean liquid.
Yeah.
How does a urinary tract full of urine get infected?
Well, you know, urine is usually either sterile or near sterile in healthy conditions. And it's good we brought up UTIs, because there are important things we need to talk about them. And we talked about kids with ear infections or throat infections. The other end of the spectrum are elderly patients who tend to get UTIs, particularly if they're in a nursing home, particularly if they're women. The anatomy is a little different, so men tend not to get urinary infections quite as much.
I mean, I hate to be cold about it, but the surface area works against women.
Yep.
I mean, when you look at the exposed geography, it's a lot less in a man than in a woman, so just naturally, women are going to have a disadvantage there.
Yeah. So, but younger women and occasionally men can get urinary tract infections. So classically with a urinary tract infection, it's pain with urination, frequency of urination, and you may develop some fevers or chills. You may get a little tenderness in your lower belly where your bladder is, or potentially in your kidneys as well. So those are infections, and you know, if you have those symptoms, you say, yes, well, maybe it's a urinary infection. And what we know for urinary infections, we can use really short courses. You know, sometimes 3 days of antibiotics are enough. And they're usually treated pretty well.
Is that because it's just not aggressive, or the concentrations don't get high enough?
Well, the concentrations of the antibiotics they get concentrated in your urine. So, you know, you take a drug, and how do you get rid of the drug? You
pee it out.
So, oftentimes, you can really nuke the bacteria in your bladder by just taking an antibiotic.
So it's like having a major funnel and a very small high-pressure hose. If you're trying to live in the high-pressure hose, You know, because essentially all of the antibiotic is going to get concentrated, flushed out the urinary tract. And when those little buggers are there, they're taking the brunt of the antibiotic.
So what happens when you get older, and this is important for all of us who have elderly parents or relatives or old themselves.
Michael, I was going to say, I hate to say, but I look in the mirror,
Yeah.
I see an old person looking back at me.
Yeah, but as we get older, typically women more than men, it's another time where you can start to get urinary infections. And if you're in a nursing home, again, nursing homes are kind of like hospitals. There are a lot of bugs that live there, unfortunately. It's kind of
You
unoriginal.
got more old, susceptible people.
Yeah,
The density is much higher. I mean, my mom lives with us.
yeah,
She's 93.
yeah.
She's the only 90-year-old in the house. If she was in a nursing home, the density of 90-year-olds are going to be a lot higher.
Yeah. So, sometimes you're, particularly if someone's cognitively impaired, and unfortunately a lot of 90-year-olds are. I'm glad your mom doesn't seem to be now.
Well, the dementia sets in, and
Yeah.
is it, now let me ask again, sorry for the horrible question,
Yeah.
but is it just that as I get older, the dementia sets in, I don't necessarily remember to take the steps for good hygiene, or I don't take them as far? I mean,
That could be part of it, but part of it's physiological.
so the immune system?
Immune system, absolutely, and then our friends, the good bacteria, may be different. And a woman's reproductive tract often has the good bacteria, the lactobacillus we talk about. And those lactobacillus help fight off the bad E. coli's.
But I'm feeding that to my newborn
Yep.
to populate.
But in adults as well. And so, in any case, the elderly tend to get their urine tends to be not sterile, let's put it that way. But what does that mean? If you look at all 90-year-olds, about half of them, their urine won't be sterile. But oftentimes that's not causing any problem. So that's the other thing that we really try to hold the line on, because you bring your mom in because she's getting a little more forgetful, for example, and you say, I wonder if it's a urinary infection. And people with urinary infections, when they're sick, it can affect the way the mind works. But if you do the test, and what happens if you come to the ER and grandma's not feeling well, they'll do a urinary sample. And elderly women tend to have bacteria in their bladders because it's not sterile anymore. There's a big urgency among some people when or when the family looks at the culture report and says, grandma has E. coli in her urine, she needs to be treated. Not always, because she might always have bacteria in her bladder. So those are the kind of more difficult things we're trying to work on.
If it was E. coli, you probably know the source.
Yep.
It's supposed to be unidirectional, but okay.
Yeah.
So somebody did the wrong swipe or
Yep.
the wrong direction, and it went.
That might be the case, but then again, even with perfect hygiene, we know that, about half of the people in nursing homes, and who knows the hygiene for everybody, but if you took urine samples of half the people, men and women in nursing homes, half of them will have bacteria in their urine. And, they're living with it.
Now you're saying that I've got E. coli living in my bladder, and somehow it stays at a level that is annoying, but that's it?
Yeah, it may not even be annoying. It's only annoying to us when we do the culture and see it.
Yeah. And that always amazes me, too, because how do you take, say, sterile, you got sterile liquid in a dispenser, and then you're aerating it. Somehow you're getting it into a little cup. I mean, there's going to be bacteria in there.
Yeah, and so they have thresholds. So we have a threshold greater than 100,000 bacteria per milliliter.
Okay. Because I was going to say,
yeah.
any way you do it,
Yeah.
you're going through non-sterile air into a container.
Yeah, or a non-sterile urethra, either a man or a
Or a woman, it doesn't matter, but one way or another, there's exposure to air which is not sterile.
Yeah.
And you're saying in a lot of cases, unless it becomes excessive, it's okay, you just leave it alone. And in younger people, you think it's just the immunological response is stronger, that I can fight it off? Not me, I'm too old for that.
That's part of it. And we have healthier microbiomes, not exposed to as many antibiotics. All those things, limit those infections or those problems.
It's amazing, as I start thinking through, because I hadn't thought of MRSA on the skin, just waiting to say, okay, somebody puncture, I see the vein, I want in.
And that's a big thing. It's one of the, we deal with this subject all the time. Someone has a skin infection that could be from MRSA, often causes boils, or they're in the hospital and they get a hospital infection from MRSA, like an infected IV site or even an infected incision. We treat it, and so the question the patient has is, do I know it's gone? And that's a tough one because, bacteria, I can't be sure that we cured you of MRSA, because what does cured mean? There's no MRSA on you. I can't guarantee that. What I can tell you is that infection's gone, but again, anybody in this room may have some MRSA sitting on our skin. It's not causing any trouble.
And it may not cause them, but if I rub up against you and you've got a cut, I may be sharing my bacteria with you and cause you a problem.
Yeah. So, we get this question all the time. Grandma's in the hospital, developed a MRSA infection. She comes out, and we say, well, if she comes back to our hospital, we're going to say, we're going to be careful with you, Grandma, because you had MRSA. We're going to take precautions so it's not spread to other patients who've had surgery, for example. But outside of the hospital, generally, it doesn't matter if you have a few bacteria on your skin. Things can happen, but you can get a puncture or a cut or something like that. But you can't protect against everything. And so we get this question, can I hug my grandchild? Of course you can hold your grandchild, maybe wash your hands. It's a good idea to wash your hands anyway.
It's amazing because my grandson, I always love when my daughter reads the books, and you sit there and she tells you how to wash your hands to make sure. And I love her for it because she's so concerned. I remember first child, and you sit there and say, there is an element of risk. You cannot be, unless, what was the movie, Boy in a Bubble? The movie about the boy with no immunological response available. So they put him in a sterile air bubble. I mean, everywhere I go, I'm going to have some bacteria.
Exactly.
And so I always joke with my daughter saying, I'm amazed you lived. Even when she taught me how to change a diaper. And she calls me to make sure I remember. I had to tell her, well, thank God you reminded me, because we only bought you one diaper. Your whole life we bought one, we never changed it. But there are certain things like just, when you came on, oh God, how many years ago? H1N1, the first show.
Yep.
You were the one who kicked off this whole medical series. And I laughed because I said, isn't it really wash your hands?
That's still the best policy, and that's how you probably can prevent getting MRSA, prevent spreading MRSA, prevent getting or spreading C. difficile, C. diff. If everybody washed their hands, That would be most of the
Oh,
battle.
they got now it's in vogue to have the little
Yeah.
squirty things,
Yeah.
the disinfectant.
And that works for most things. Again, there's some exceptions. And, using those, but also washing your hands is probably the way to go.
And we're so used to it coming out of a biotech lab that when you first came on, it was like, I don't want to seem rude, but we all know.
Yeah.
If in and out of the lab, we always wash our hands
And wear gloves.
and wear protective gloves.
Yeah.
Okay, so we're not going to wear protective gloves going in and out of different rooms of the house, but if we go into certain rooms or certain areas when we come out, you kind of expected to wash your hands.
Yep.
So we're coming to the end. Seems like for the non-physician folk like myself, the message is go to your physician if you have a question. Let a trained person decide when an antibiotic is appropriate, if an antibiotic is appropriate.
Yeah.
And then if you're given a treatment, there are no options. Follow the dang treatment.
Exactly. And just know that antibiotics for their purpose, killing bacteria, are great. But you have to discuss that with your doctor. How likely is it that my cough is due to a bacteria or virus? How likely is my sore throat due to bacteria or virus? If it's not a bacteria, antibiotics won't help.
And that's probably the best idea that we're telling people is, look, you trained forever to learn how to diagnose. Self-medicating, really, when people say, well, it can't hurt. I'll take a day and a half of these antibiotics I had left over. And the reality is it can hurt.
Exactly. And again, something that's unfortunately very common now, grandma or grandpa having bacteria in their urine. We understand, and it takes us a while to understand, when to treat and when not to. And sometimes we have to live in harmony with the bacteria.
Right.
We don't always have to kill it.
Well, thank you.
Okay.
I don't think most people understood antibiotics, so this is really great. As always, it's always amazing the medical treatments available here at the center of the universe, the knowledge, the experience. You can't get better. The little red building that was the Milford Hospital is now a world-class medical center. Take advantage of it, and hopefully, if you're listening to shows like this, you'll understand why and when and how to properly get treated. So thank you again. As always, to our 6 loyal viewers, may God bless, and may tomorrow be a healthier day than today. Thank you.
Thank you.
Not too long since I've been home.